Hello, good evening. Welcome everyone. Thank you for joining us tonight for session 1 in our series, The Clinical Benefits of Multidisciplinary Team Care in Residential Aged Care Facilities. Tonight's session topic is physical therapy for deconditioning patients. My name is Charles Broadfoot and I'm one of the Professional Development Officers with Hunter New England Central Coast Primary Health Network. I would firstly like to acknowledge the First Peoples and traditional custodians of all the lands in which we are meeting on tonight, pay my respects to elders past, present and emerging, and also welcome any and all of our Aboriginal friends and colleagues who may be joining us online. Tonight's session is being recorded and the slides and the recording will become available in our PHN Education Library from tomorrow. So to access this, you just head to our website, thepHN.com.au, and click on the Education tab. We will be using Slido tonight for your questions and also the session evaluation survey. So you can access the polls and Q&A tabs of Slido on the right-hand side of your screen if you're watching from a computer or laptop. Alternatively, you can head to slido.com, so that's SLIDO, and enter the event code AH1, which stands for Allied Health, and then the number 1. Or a third option is by scanning that QR code that you see has popped up in the corner of your screen. Please type your questions in throughout, at any time throughout tonight, but please know we have allocated some time after the main presentations for a Q&A panel discussion with our speakers. It's now my pleasure to introduce tonight's facilitator, Dr. James Wolstenholme, who's a GP from Mingara Medical Centre on the Central Coast. James supports a large cohort of older patients residing both at home and in residential aged care facilities. So I'll now hand over to you, James, to introduce the session and tonight's speakers. Thanks very much.
Thank you, Charles. Good evening, everyone, and welcome to our session on the roles of multidisciplinary teams in providing care to residential aged care facilities. Sorry, excuse the hair, desperate for a haircut like a lot of us, I should imagine. So this session is focused primarily on deconditioning and the role of physical therapies in the setting of aged care. I'm sure we can all agree that aged care residents are a particularly vulnerable cohort when it comes to physical activity and the implications that can have for overall health. And this, of course, is especially true in the context of COVID restrictions under which nursing homes have had to operate for the majority of the last 18 months or more. And which restrictions have necessarily reduced residents' contact with their families and the outside world in general, and in particular, healthcare teams. So we're fortunate to have with us this evening 3 speakers who are collectively going to tell us, I'm sure, everything that we need to know about enhancing care provision in this context. A little later on, we will be hearing from 2 allied health providers who will give us their perspective on the roles of their individual specialties in the aged care setting. That's John Stevens, who is an exercise physiologist, and then Ellen Marshall, who is an occupational therapist. But first up, I would like to introduce Wendy O'Meara, who has an extensive background in general practice, both working in nursing roles and as a practice manager. And Wendy is going to talk to us about the impact of deconditioning in the aged care setting, the role of allied health providers, and the recent MBS changes, which have been put in place to support allied health care provision in the aged care setting. So as Charles said, if you have any questions, please put them in Slido. We'll get to those at the end. So for now, I would like to hand over to Wendy. Thank you.
Good evening, everyone. Thank you, James. As James said, my name is Wendy, and I am a practice manager in a large multidisciplinary practice in Brisbane, Victoria, during the week, and of a weekend and weeknight, I do some education consulting for LATA Consulting. So thank you for joining us tonight. Tonight's session is the first in a series of 3 that we will be presenting to you based around the new initiatives introduced recently in December last year for the additional therapies, so the addition of physical therapies with the introduction of mental health item numbers available for allied health professionals to provide care for residents of our aged care facilities who have been impacted by COVID-19, which, as you know, has been quite a lot of them. So I guess to understand the Medicare component of this initiative, we have to understand where it's coming from. Why do we need to support this initiative, and what we as GPs and allied health can do to ensure that our residents living in the aged care environment get the best opportunity to improve their health outcomes. So I'll get started if that's okay. So the first slide, we'll talk about the learning objectives for tonight. So at the completion of this module, participants will be able to understand the physiological aspects of deconditioning. We'll also discuss the impact that COVID-19 has had on residents of aged care facilities, with particular reference to deconditioning, and that will come mostly from Ellen and John. And also we'll discuss the benefits of physical therapy to promote and improve independence and quality of life for our residents. And finally, we will also be discussing the key components of the new MBS item numbers for allied health service provision to aid in the process of reconditioning. So it's quite a bit to get through, so I will keep going if that's okay. As James said, any questions, please type them in the chat box and we'll get to them at the end of the session. So let's put this into some kind of context, shall we? So this initiative was introduced as a direct result of the Royal Commission inquiry into the quality and safety of aged care within Australia. It was set up in 2018 by the Governor-General, Sir Peter Cosgrove, as a response to the growing concerns about the quality of care that our aged care community was receiving. The final report was tabled in March this year. However, the inquiry was active during the COVID-19 impact. So a lot of it came from the impact of COVID-19, which is, even though it wasn't great, it was probably a timely thing while the inquiry was being established. The final report has recommended 148 wide-ranging changes to the fundamental reform of the aged care system. And as much as I'd love to go through each and every one of them with you, I'm only going to focus tonight on the three most relevant to the presentations that we will be covering. So, recommendation 3. The Australian Government should urgently create Medicare benefit schedule items to increase the provision of allied health services, including mental health, to people in aged care. So just so that we're clear, there has been no provision for mental health services in aged care facility prior to now. There was the ability to refer through a chronic disease management plan for allied health mental health services if the condition was a mental health concern, but there's been nothing like this in the past. So this is a fantastic initiative. They also recommend in this recommendation that any barriers, whether they be real or perceived, to allied health professionals being able to enter aged care facilities should be removed. As we know, when we're in lockdown in the last 18 months, and if you're not aware, I'm coming to you from the lockdown capital of the world, Melbourne, our aged care facility, the impact here was just phenomenal with the isolation and the fact that providers couldn't get in to provide care for these residents. Recommendation 38 discusses ensuring that residential aged care providers include access to allied health services appropriate to each person's needs no later than the 1st of July 2024. And it also goes on to encourage or to govern that arrangements between aged care providers and allied health must be established to provide services, and they must either employ or retain a range of allied health services in their facility to ensure that the care provided to the residents is appropriate to their individual care plans. So I think this is a very important statement, the individual care plans, because this is what we will be covering in more detail later. So the services should be referred for the individual's needs and not across what the funding of the facility is directing. And I think allied health services find that quite a frustrating thing when they go into facilities, is that the care plans that they're working with is based on a funding model versus an individual model. And please correct me if I'm wrong later, Ellen or John. And the final recommendation we'll talk about is recommendation 61, which is to create new MBS item numbers, and I do use the word new because they are, from the 1st of November 2020 for allied mental health practitioners to provide services to our aged care residents. and that includes psychologists, occupational therapists, and social workers. And we will discuss this component of the recommendations of the plan in the final webinar, in the third webinar that I'll be presenting. So hold that thought, because we will cover that in quite a lot of detail in the third presentation. Okay, deconditioning. What is deconditioning? So deconditioning is the physical, psychological, and functional decline as a result of prolonged inactivity and associated loss of muscle strength. If you don't use it, you lose it. So that's basically the age-old saying, but it could never be more true for this presentation. So I know myself, if I have long periods of inactivity, for example, when I'm traveling on a plane, which I really wish I could be doing, the last time I took a long flight, I got off the plane and I was stiff and my muscles were aching, and that was just after a few hours. So imagine the impact that it's had on the residents of aged care facilities who've been isolated or quarantined in their rooms for up to weeks at a time. It's just shattering. Deconditioning can occur at any age, so it is not necessarily a condition of the elderly. However, it is known that deconditioning can occur as a natural process of the aging process, or natural function of the aging process, and those components of deconditioning are not reversible. So the deconditioning we're talking about is based on just long-term immobility. So as I said, can occur at any age, but does occur faster amongst the elderly, and it's usually more severe. Excuse me. It's frequently associated with hospitalisation in the elderly. So the elderly gentleman or lady that fractures the NOF or attends hospital for a long period of time often has to go to rehab after they've been discharged, purely to get them being able to ambulate and look after themselves again. And obviously COVID-19 impact with the lockdown has been a similar relationship to being in a long-term hospital stay. And just a little bit of information which I found quite surprising: it only takes 2 weeks of physical inactivity to lose almost 30% of our strength. So that's pretty alarming, particularly when you're looking at the elderly or the frail, whose strength is limited as it is. So signs of deconditioning: functional loss. So obviously functional loss is purely the inability to perform the normal working movements of the body. So when residents are bedridden or isolated, not being able to move around, their functional loss can be quite significant. Inability to complete some of the ADLs, so being able to get out of bed and brush their teeth and do their hair, clean, wash themselves, shower themselves, dress themselves, all those things this is impacts on. Diminished muscle mass and strength, as we just discussed. And of course, things like muscle shortening, which manifests in contractures and changes to joint structure, so stiffness. So as I said before, if we're sitting or immobile or not active for long periods of time, these things can happen to a normal, healthy person. So the impact on the elderly is much more severe. And of course, marked loss of leg strength. So deconditioning can lead to increased risk of falls. So this is something we're very mindful of in the elderly, the risks of falls and the severe impact it has on their health outcomes. It also increases frailty and can also increase risk of pressure areas. So as we know, if they're sitting, immobile or sedentary for long periods of time, pressure areas can develop. And unfortunately, with the impact of COVID-19 in the facilities, the staff are so busy dealing with other things that the normal daily care that they were able to provide, or the limited access to allied health services, will put them at increased risk of pressure areas, and they're a lot harder to deal with when the skin integrity breaks down. Obviously, immobility is a big factor, and of course, the actual ability to lose the actual ability to perform any or all of the ADLs. So, sometimes it can start off with just not being able to brush their hair or dress themselves, when it gets to the point where they can't actually do anything for themselves, which is such a shame because it's such a loss of independence for them. and of course depression. So this does precurse the third presentation on mental health, but depression and physical health, or mental health and physical health, do go hand in hand, and if one is affected, the other is normally as well. So the immediate impact of reduced physical activity, it affects the main systems of the body, so the cardiovascular system, the respiratory system, and the metabolic deconditioning. As you know, COVID-19 also has impacts on these all systems of the body as well. So when you put the two together, it can be quite alarming. It also has the effects of loss of strength and balance, which is where our allied health services are so vital to improve or regain that strength. Insulin resistance and increased fat mass due to the metabolic problems, so they have got more likelihood of developing these. And of course, the increased social isolation and decreased mental health and well-being. It's pretty scary, isn't it? The long-term impacts, so that's the short term. The long-term impacts of physical activity is falls. So actually to progress from the risk of falls to actual falls. It also, long-term impacts are depression, which is in aged care at the moment. They say that 70% of our residents are struggling with depression. Type 2 diabetes as a result of the metabolic conditions, cardiovascular disease, musculoskeletal problems, and of course, depression, which we talked about before. However, with all that bad news, there's always something good at the end of it. The good news is the effects of deconditioning can be reversed. Excuse me, it looks like I put my pretty picture over those words there. It can take twice as long to achieve. So a normal person a mild case of deconditioning can take 2 weeks to occur, but can take up to 4 weeks for reconditioning to occur. So as you can see, it's quick to happen, a lot quicker to reverse. So that's something that we really need to get started on now, because we have so many residents who are deconditioned, and trying to encourage the access to allied health and using this new initiative that we've got is vital in providing those services for them. So now that we've looked at deconditioning, I'd like to look at the impact that COVID-19 has had on the residents in our aged care facility. And for most of you, you're already well aware of it, as is most of the general population. It's been devastating to see the impact. COVID-19 has, without a doubt, been the greatest challenge our aged care sector has ever faced. Never before have they had to deal with the impacts of this. The aged care sector is overworked, under-resourced, and now significantly traumatised as a consequence of COVID-19. The COVID-19 pandemic will be preceded by a deconditioning pandemic, and reconditioning program needs to be implemented. So the World Health Organization has stated that with this pandemic, the next pandemic we're going to be experiencing is the deconditioning. So the loss of immobility and muscle strength for our elderly is something that is going to occur. So we as GPs and allied health providers need to be mindful of that and start working towards the solution now. The first aim of deconditioning or reconditioning is to reverse the effects of deconditioning and improve the quality of life for the residents. So that is paramount, giving them back their independence, giving them something to look forward to. And just a visit from the allied health of the GP is always something to look forward to. Sorry, my slides, there we go. So, sorry about that. So the statistics, just to give you a bit of refresher, these statistics are from the 1st of October 2021. There have been 728 deaths in residential aged care facilities in Australia. And considering that we're only sitting at just under 900 in total deaths for the country, this is pretty scary. And to add insult to injury to the world's most locked down city, we're also we have the highest number of deaths here in Victoria, with a total of 661, with New South Wales sitting at 62 as of the 1st of October. As of the 1st of July, New South Wales had only 2 deaths in aged care facilities, so there has been a significant increase in the last few months, obviously due to your current situation. Obviously, the remaining balance of those numbers is other states or territories within Australia. And as of the 1st of October, there have been 592 cases of COVID-19 in aged care facilities in New South Wales. So we're painting a picture here, aren't we? Contributing factors to the deconditioning or to the impacts of COVID-19 has also been the limited or reduced access to healthcare for these residents. So as a result of the pandemic, as you know, many of the facilities were put into lockdown and there was no access to GPs or allied health services during that time. So that's probably one of the contributing factors. Obviously, no service provision at all or provided in a reduced capacity or digitally. Now, digitally works for us in this environment. We're young and we're IT savvy, or I like to think I'm young, and IT savvy, so we're able to do that. We're able to move with the times. But the aged care population aren't. And it also relies on assistance from someone to help them do it. So yes, if you've got an iPad and you can do a telehealth consultation with your resident, that's great. But if there's no one there to assist that resident to do it, then it doesn't work. The other contributing factor, of course, is the inability or the unwillingness of the residents to actually access those services, mainly through fear of going out from the facility, fear of getting sick, fear of leaving their room in case they got sick and died. So all these things have contributed to where we are at the moment in the aged care sector. The other important lacking contribution was the lack of family or social support. So for anyone who has spent a lot of time in aged care, you can see they have the mothers, have the daughters or the sons or the husbands or the wives are there every day to support the staff in supporting their loved ones. So having them take them for a walk around the facility or take them outside to sit in the sun or just to walk him down to the dining room at lunchtime. With that lack of support, that's actually has made them more isolated and more likely to be deconditioned. Residential aged care facility workers, unfortunately, have had to shift the focus of their main attention to infection control versus giving the residents the care that they need. Please don't misunderstand me. I don't mean that the residents didn't receive care. I just mean that those things that they were normally able to receive, those additional things from the aged care workers wasn't happening due to the significant impact it had on them. They were seeing more agency staff and temporary staff because of the results of outbreaks where staff were having to quarantine. So new staff were coming into the facilities who had no idea what the residents were all about or what they needed. And the residents didn't, they were unfamiliar to them too. So there was that breakdown in that, the whole communication process of what they needed and what was required for them. And of course, the inability for allied health services and other service providers to attend. So a lot of the facilities locked out anyone who they felt was not necessary, which was pretty much everyone. And of course, the risks associated to those providers attending. So allied health providers and GPs were reluctant to go to facilities where the lockdowns were, purely because they also have a business to run and loved ones to think about as well. So I think the whole fear factor of COVID-19 has got us, I think we're beginning to learn to live with it, and that we understand that it's going to be part of our life now. But prior to this, when we look at the impact where this all started from, this was a significant impact or contributing factor to reduce access to care. So what does the evidence tell us? Deconditioning, what can we do about it? Exercise, exercise, exercise. It is the best prescription. We need to look outside the space here, and as prescribers or as doctors, prescribe exercise as an intervention. So when you attend your aged care facility and you're looking at the shared care plan within that facility and you're seeing what the resident's experiencing, think exercise, because that is proven that it can, and I'm really keen to hear from both John and Ellen about their experiences with that in the facilities. So I won't pretend to know how it works, but I'm really looking forward to hearing what they've got to say about that. The number one intervention is resistance exercise. So again, I'd love to hear how that's going to work and what we can do, or who we should be referring to actually get these exercise programs up and running for our residents. There was a Japanese study that I found, and as we know, Japanese are the doyen of healthy aging, and the recommendation was that if a resident, or anyone, I guess, performs between 30 to 80 minutes of exercise 1 to 5 times per week for a period of 6 to 36 weeks, there has been a significant improvement in the muscle strength and physical performance of people undertaking that exercise. The other thing it's improved is their mental health. So this is actually, and it's brief, just basically so you can understand the system I was just talking about. And again, it's a Japanese system, and it was actually given to me by a leading geriatrician in Melbourne who's been working in the aged care facilities with the residents and has been implementing this program with the help of the EPs and physios. It's basically a program of 12 months with twice per week activity or twice per week exercise sessions of 40 minutes with groups. So 6 to 8 people is a great manageable number, and it's often physio, EP or OT led. The exercise can be conducted in a seated environment, so you don't have to be ambulatory to participate, and the plus of all that equals great results. And that's just a brief outline of what the 40-minute exercise program was made up of. 5 minutes of warm-up, 15 minutes of gymnastics, and then some ball activity, standing activity, and some cool-down. So something to keep in mind, but as I said, Ellen and John are our go-to people for this, and we'll see what they have to say about that. So basically, what should be provided? There's 2 types of therapy. You have intensive therapy, which is usually in the acute setting, and then you have maintenance therapy. So intensive therapy is delivered by allied health or care staff under the direction of allied health on a temporary basis, and it's designed to allow the resident to reach a level of independence, after which the maintenance period can take over. Then you have the maintenance therapy, which is again led by the allied health or care staff under direction of the allied health providers, and is designed to maintain the resident's level of independence. So it is a long-term program we're looking at. So we have got the ability with these added incentives to actually get something happening and make a real difference to these people. So the services to refer to, of course, these are the services that will be available under the new funding, and this is why I've only listed them, but of course the number of services you can refer to as a GP are limitless. But the services we're looking at are physiotherapy, exercise, which is to diagnose and treat your injuries, exercise physiology to create exercise and fitness regimes for these residents, and of course OTs, whose ability to adapt things and give them new ways to do things. So if they've lost the functionality to do it one way, offer them alternatives on how to do it a different way, and of course to change the environment that they're living in to suit their needs. So an environment that your resident was previously living in may not be suitable anymore. So OTs are great at being able to assist with that. So you can see the benefits of these 3 physical therapies and how they can help your residents. So the temporary MBS item numbers, so obviously this is the underpinning reason for these presentations, is to advise the GPs and allied health of the services. Tonight we are really just going to be touching on it, just a brief overview, and the next session in 2 weeks will give you a deep dive into each of the item numbers, what the requirements from MBS are, and what the allied health need to do, what the aged care facilities need to do, and what the GPs need to do to get this all moving. So this is really just to give you an overview. So, and we'll only be talking about the allied health initiative tonight. The mental health one we will cover in the 3rd session. So the allied health initiative was introduced on the 10th of December 2020, and it will run through to the 30th of June 2022. I think what's the most alarming thing about these dates is that it is now October 2021, and to date every presentation that I have done on this topic, no one knew about it prior to the presentation. So, and even discussion with John prior to the presentation tonight, he was unaware of it. And he's a GP who's very active in the aged care environment. So it's I beg your pardon, and not John James. So something that we don't know about. And again, we go back to that context before. If we're not going to use it, we're going to lose it. It was temporary MBS item numbers, and the word temporary is purely that because it is only in place until 30th of June 2022 when it will be reviewed by the MBS task force group, and we all know what they do. If we don't use it, they take it away. So please start using it. And it's available to improve access to multidisciplinary care for residents of aged care facilities. What it leads to is 5 additional physical therapy services and 2 additional exercise physiology group therapy services. So the 2 extra sessions are only for exercise physiology, but the other 5 can be shared between EP, OT, or physio. And so that now gives you a total of 10 individual and 10 group sessions per calendar year. Now, if anyone's thinking like I am, we're October now, so now's the time to get it going because we've got 2 months to get lots of visits in before the 31st of December when the item numbers all roll over again. So keep that in the back of your mind. It's been implemented, of course, in recognition of what we've already been talking about tonight, that residents of aged care facilities are at a high risk of deconditioning as a result of restricted activity. I think we all are, really. Many residents, this is really important, I think, many residents have actually contracted and recovered from COVID-19. So they're the ones that require the rehab to restore that functionality. Some of them have been in hospital for weeks or bedridden or bedbound, I should say, not ridden, bedbound for many, many, many weeks, sometimes months. So these are the residents we really need to focus on. And I'm hoping that each and every one of you GPs that's listening in tonight can think of at least one person that's going to benefit from this. So the eligibility requirements, the resident must be currently managed under a multidisciplinary care plan. Now, obviously, as a GP, we contribute to the care plan created by the aged care facility, but what we don't do well is actually contribute. So we do it in the daily activities of what we do. So every time we go to that facility to see our residents, we're contributing, but we're not actually billing Medicare for it, or we're not generating that item number, which then will not generate these additional services. So we do it, we just don't bill for it, or we don't recognise ourselves for it. Obviously, GP management, team care arrangements and shared care plans are all part of that, particularly if the resident has transitioned into aged care. And of course, the Aboriginal Torres Strait Islander Health Assessment, which is new to this program, or it's new to the MBS. We were able to do Aboriginal Torres Strait Islander Health Assessments on residents, our patients living in the community, but up until now, we were not able to do it in the aged care facility. So this is something also, if you have residents who are Aboriginal Torres Strait Islander, they are all eligible for it now, so they should be being captured. And it covers the same guidelines. So GPs, what you can see here, the top part of the table is the existing item numbers that you use. The bottom half of the table is for the OMP. So top is VR, bottom is non-VR basically. So at the moment, when you attend the facility and contribute to the care plan of your resident, you would bill a 731 and you would not be able to bill anything else. So it's one of those item numbers that is standalone. If you bill it, they will not allow you. There's no co-billing allowed. However, if you now bill the 93469, which is the equivalent to Medicare, must be face-to-face, you can then bill the call-out fee, so the flag fall fee of the 90001, which has been available to us for well over 12 months now, 2 years, I think, to when we attend for the normal standard consultation item numbers. So if you go and do a regular visit, you can bill the 90001 on the first service that you perform. The 90001 is now available to be billed when you do your 731s or the telehealth, or the 93469, which is the aged care equivalent. So please start using that item number. Don't use the 731 anymore. The other benefit or the other important reason to build a 93469 is it identifies that you would like to have those additional 5 physical therapies generated. If you continue to build the 731, those 5 physical therapies will never be accessed. They'll be, when the provider provides them, they'll be rejected from Medicare. And of course, the second item number is the 715, which is your Aboriginal Torres Strait Islander Health Assessment, and the 93470 is the equivalent to that. Again, you would be billing that item number, not the 715, and again, you can claim the flag fall fee for that as well. Remember also the benefits to having the Aboriginal Torres Strait Islander Health Assessment is you can access these additional physical therapies, but you'll also continue to be able to access those 10 supported services by a practice nurse or an Aboriginal health worker. So it's really beneficial to be looking at these item numbers. So as I said, this is just a brief overview. We will deep dive into this in the next session. So please, if you can think of any questions that you would like answered or would like more information on, when you're asked to give feedback, please do that and let me know if there's anything that you would like me to cover in the next presentation. So what the changes mean, what did we have before? Initially, we could refer our patients to 5 allied health services for a full range of services, so not just physical health. There was podiatry or dietetics or speech pathology or lots of other services. Excuse me. And we could refer also for 8 group sessions for a resident who had type 2 diabetes in any combination, so it didn't have to be EP. It could be 2 group sessions for a diabetes educator and 3 group sessions for an EP and 2 for an OT. So going back to the 10 sessions in the group sessions, the additional 2 are only for exercise physiology. And as I said, that these are the other services that you were previously able to use for the group sessions. What does the new program look like? So basically similar, but instead of having 5 allied health services, you are now available to refer for 10. With the 5 physical therapies, obviously the additional 5 must be face-to-face, and who would want to deliver physical therapy over the phone anyway? It's a bit difficult, but so they must be face-to-face. Allied health providers can now charge the flag fall fee for the first resident, which is fantastic as well. So the physiotherapist, exercise physiologist, and OT, as you said, as you can see, come into play again here. So the focus of this therapy is all around those providers. And you now can provide the 10 additional or the 2 extra sessions, giving you a total of 10 group sessions. That's quite a comprehensive range of services for someone to get them started. The important thing to also note is that these services do not have to be bulk billed. So as an allied health provider or as a GP, you can charge for these services, but they do need to be, you do need to obtain informed financial consent. So if you're going to be charging your residents for these services, you must obtain, they must be aware of that. So MBS requirements for the allied health, they must be registered with Medicare. The provider must be listed in the original care plan, and if they are not listed as a provider and they are a new provider, you must review the care plan, add them to the care plan and give them a copy of that. Obviously, the care plan is the aged care facilities care plan, so there should be the ability to view that anyway when the providers come into the facility. Feedback must be provided to the practitioner, so the referring practitioner, after the first and final service, and the referral must be on an appropriate form. So we're all very familiar with the EPC form that's available. If you're not, please let me know. I'll make sure you get a copy of it. And the services must be at least 20 minutes long. What's new? This is fantastic. They have introduced a once only, and when I say once only, it's once per year, initial consultation for allied health providers to charge. So now when they go to do their first visit with their new referral, they can do a 30-minute consultation, which makes up part of those 10 sessions, but it does retract a higher rebate. So instead of $50-something, I think it's $54.60, it's $82.60. And with the addition of the flagfall fee, it's quite an attractive remuneration for someone to go into the facility. And as I said before, it does not have to be bulk billed. So you may want to come to an arrangement with the patient or the resident for a private paying fee, but they are getting quite a considerable rebound. Obviously, if you privately charge the service, you would then bill the 9,000 for on a service you're going to bulk bill, because you can't privately charge the call out or the flag fall fee. This can be claimed once per year per provider. So if you have 3 providers working with this resident, each of those residents can conduct that initial assessment. Again, must be provided face-to-face, and that's the flag fall fee rebate for attending the facility. But wait, there is more. If you're like me and you're thinking, hang on a minute, if I have 5 services to provide, so I've sent, and let's use podiatry as a perfect example, because so many of our aged care facilities use podiatry as their preferred provider for their care plans. If you're going to allocate 5 sessions to the podiatrist, and those 5 sessions are used over a 12-month period, so most times the podiatrist books the resident for 5 10-week visits, there's 50 weeks of the year gone, you will never be able to access these additional therapy services because they don't kick in until the first 5 have been used. So please keep that in mind when you're looking at your referral patterns, and include perhaps, and again, it's an individual thing, it's a practice-based thing, but perhaps either look at decreasing the number of podiatry services you generate initially, so that you can get the 5 services in place before you then refer for the additional 5. It's a tricky one, and it's really a whole nother conversation, but I do want you to be aware of that. If you're going to give your EPC referrals to the podiatrist who spread them out over 12 months, the access to the physical therapies will never happen. The other thing you must be aware of is that we should not be billing Medicare, or Medicare should not be charged for services that are mandatory to be supplied at an aged care facility. I think the Aged Care Act of 1997 mandated that there are certain services that must be provided to the resident. I don't know whether that's an individual choice or whether there is a list of them. I couldn't find it no matter where I looked, so I'm hoping that Ellen or John could perhaps help me with that. But it relies on the tracking mechanism is going to be the problem here. How do we keep track of how many visits I've had, so that we can then refer? I will touch base more on that in the next presentation, but just something to think about moving forward. And obviously we must do regular care plan reviews to make sure. That's one way of checking it. Yes, the physio has been in a couple of times, or the podiatrist has been in a couple of times, because you're able to actually visualize that. We did touch on this before. Basically, the Aboriginal and Torres Strait Islander health assessment can be conducted every 9 months, so it's the same as the community-based one, and it does allow those referrals that we have already talked about. So it does generate the additional 5 therapy sessions. It also generates the group sessions and the flag fall fee, and of course the additional 10 follow-up services. So please keep them in mind if you have residents who are in that group or who are living in the facilities, that it's a really valuable tool, and you can use your practice nurse to assist you with these. In addition, I am mindful of the time, so I'll try not to take up too much of the time. There has been a targeted measure. So part of the government's funding, I think $63 million has been put into this program, and $12.3 million of that has been given to PHNs to target and commission group allied health services. So above and beyond what we're talking about tonight, any facility that has experienced a COVID-19 outbreak is eligible for this additional funding, which provides physiotherapy, EP and OT for residents in group sessions. And it's a great program, actually. The way it will work is the aged care or the allied health provider will go into the facility and meet with the staff of the facility and identify eligible residents. So pick a cohort of residents who would be eligible for the group service they're going to offer. This is at no cost to the resident, by the way, and undertake a one-on-one assessment to identify the individual needs. So meeting with the facility staff, then having a one-on-one assessment with the resident, and then establishing twice weekly group sessions of 6 months. And when we go back to that Japanese model, that's exactly what they are saying has significant outcomes. So that's fantastic. And I'm really keen to see where that's going to lead in the future. And I did talk about this before. Under the Aged Care Act 1997, the aged care facilities are required to provide specified allied health services. So it's probably worth speaking to your facility and finding out what they are, what they provide at their facility, so that you know what not to be referring to. So you can actually refer your services to those that are not provided already. I am going to really touch briefly on this, and I will talk about it more in the next presentation, but DVA Gold Card holders who live in residential aged care facilities and who are low-level care can have unlimited access to any service. So any physical therapy. It's been around for 2 years. Again, it's one of those things that's not well known, but it was introduced 2 years ago. It allows a cycle of 12 visits or 12 months, whichever comes first, and you can have as many cycles in that 12 months as you would like. So if you refer your resident or your DVA Gold Card holder for a cycle of care under a physio, and the physio completes those 12 cycles or those 12 visits in 3 months, you can then refer them for another cycle of care, which is another 12 months. And there can be as many cycles of care with other providers as well. So you could have a cycle of care for physio, and a cycle of care for an EP, and a cycle of care for an OT, and a cycle of care for a chiropractor. So as you can see, and I don't really want to rush through this, but I will spend more time in this next time. And even though it's not related to the funding, it's such a valuable resource for anyone who has DVA Gold Card holders in their facilities and would like to help them improve their health outcomes. And I talked about the multiple treatment cycles. There is a process in place. There must be a care plan created for the resident, and an end of cycle report must be completed and sent back to the GP. So for all of those physical therapy groups who are unaware of this and you have any more questions, I'm happy to take those via email, or just we will deep dive into it a little bit more later. And as again, the level of care, they must be classed as low level of care. And if you're not sure, check with your aged care facility as to what level of care those residents are classed as. So to sum up, ladies and gentlemen, the short version, the impact of COVID-19 on the physical and mental health of our elderly has been profound. It actually is, it's heartbreaking. And only by working collaboratively, GPs, allied health, aged care facilities, can we make any change for these residents. We need to review the care plans. We need to refer our residents for these physical therapies, and we need to discuss. So we need to have case conferencing with these providers and see where we're at and get the big picture, because the unique relationship GPs have with their residents is up here on the scale, and you are in a valuable position to make this happen. We need to improve the health outcomes and quality of life for our residents post-COVID-19. And as I've said more than once in tonight's presentation, if we don't use these item numbers, we will lose them. So thank you everyone for tonight. I'm going to now hand you back to James, who's going to introduce the next speaker.
Wendy, thank you very much for taking us so thoroughly through the background and evidence on this issue. And certainly the issues that you point out echo my own personal experience. I'm not at all surprised to learn that up to 70% of aged care residents are struggling with depression in this context. And clearly this is a highly timely initiative to address this. It's interesting that you're not just myself who hadn't heard of at least some of this before this evening, but that's your experience more widely, is that this information has been poorly disseminated, or so it would seem. But I guess that might be partly because a lot of us have, there's been a lot of new information with regard to the pandemic, and this has probably got lost somewhere within the system. But the message pretty clearly seems to be that GPs need to be proactive in using these new item numbers and addressing the problem. So thanks again for taking us through that. I'd like to hand over now to John Stevens, who is an exercise physiologist with a particular interest in pain and mental health management across the lifespan through integrated physical and behavioral strategies. Over to you, John. Thank you.
Thanks everyone for coming on board, and I want to thank the PHN for the opportunity to present. It's a real exciting time to have extra item numbers to provide valuable services to people with, and I echo a lot of things that Wendy has already mentioned, in particular just how difficult it is to get the word out that these services are indeed available. In fact, one thing that Wendy had mentioned last around services for entitled veterans or gold card holders in residential aged care, DVA has actually moved to allow allied health services into high care as well, as far as I'm aware. So, and that's come along in line with services now available, obviously, that we're talking about through Medicare. So, what I would love to take you all through is a little bit of the perspective of the exercise physiologist. I would like to think most of you out there have met an exercise physiologist, have some idea of what it is that we do, but I don't want to necessarily take that too much for granted. I run an exercise physiology practice called Kinetic Medicine. Oftentimes, people's understanding of exercise physiology and this word kinetic make people a little nervous and think that we're into some kind of woo-woo type endeavor, but really the name of our practice is to echo what it is at its core to be an exercise physiologist, and that is we use movement and exercise as medicine. And what I want to frame for you all as we go on to this little excursion of what it is to see decline in aging through the lens of exercise physiology is to consider that exercise physiologists are often seen as kind of the fitness person in health, this quasi exercise person who's quite enthusiastic about gyms and reps and sets and weights and running and all of this kind of stuff, when in reality, our goal is to try and make exercise medicine accessible for every single person because of just how robust our evidence is about the effectiveness of exercise for its therapeutic benefits. So we have practices all over the mid-coast region from Taree all the way down to Bulahdelah, and we also have practices in the Port Stephens region. We're fortunate enough to be working with a number of aged care facilities and residents in those facilities, and so everything I'll be sharing with you is based on our experience of having worked with those individuals. We also have some aged care facilities we're working with through our practices down in the Murray Riverina area around Albury and Wagga Wagga. And the thing that I've come to learn is, regardless of where we are, life in rural and regional aged care is particularly difficult to have service accessibility. And so all the more important it is that we have access to these item numbers. So why would you choose an exercise physiologist to be involved in delivering services into aged care? Well, I want to propose this idea that the exercise physiologist is a clinical scientist. And in fact, I would advocate that all modern allied health professionals moving into this domain of being clinical scientists. That is, we look to apply solutions based on the evidence, oftentimes novel solutions that we're testing and retesting based on having a good reason for providing an intervention. And so I thought I would take the time in the 10 or 15 minutes I have with you all to try and turn you into exercise physiologists. So if you're okay to go with me down this rabbit hole together, we will go on a journey to unpack the physiological cause and effect of decline and why exercise can be so potent in terms of achieving some kind of reversal, mitigating rates of decline and preventing even some areas of decline. if there was a more perfect picture, I couldn't paint one for you. Sorry there, my internet seems to have lagged. If there was a more perfect picture of how the exercise physiologist views aging, I don't know how I could paint it for you. You can see here that there's this complex interrelationship between lifestyle, biological and psychosocial factors across the lifespan that affect the individual. And those effects are exerted on the muscular, nervous and skeletal system that ultimately result in a whole range of often subclinical presentations, but very often that progress into clinical presentations. And it's both through leveraging some of the redundancy in these systems that will allow us to build up an individual's system resilience against disease process that will help us to ultimately overcome or mitigate decline. And when we talk about redundancy, we're talking about the multi-systems that we have that do similar roles with one another. And we can leverage effects on some of these systems to affect relating compatible systems. So the main thing when we're talking about decline is we're talking about sarcopenia, and that is muscle mass loss. We know that in individuals aged over 75 years that muscle mass loss is fairly something we can take for granted, and so we can see that muscle mass loss is somewhat more significant in men ever so slightly than women per year, and we put this down to reductions in testosterone in males as they advance in age. But what's really alarming is that during periods of significant physical inactivity and sedentary behavior, like when someone is incapacitated or when we enforce different constraints on individuals like we have in residential care during this worldwide pandemic, we see much more marked losses in muscle mass. We can see up to a kilo loss of muscle mass in just 10 days in some settings. And so this is quite alarming, and I quite like to use this little image from a study I saw long ago, a case study paper that was published, where you can see in the image there the nice grey tissue of muscle mass in the 23-year-old man, and then the significantly changed tissue mass and tissue quality in the older individual. On that little picture you can see there. And so what we know about sarcopenia, as Wendy had mentioned, is that exercise and nutrition alone are the most superior opportunities for us to intervene. We can see skeletal muscle mass gains happen even in very old individuals, and it's only in some very select circumstances system failures so dire that they would fail us to be able to develop more muscle mass growth. And I do want to emphasize, because there's no dietitians here to advocate for themselves, but we really need those adequate nutritional building blocks for exercise to do its work. So that is a big caveat that needs to be brought up at this time. But one of the other things that tends to commonly fail us when we're looking at interventions for residents in aged care facilities, when we're trying to combat the effects of sarcopenia on decline, is we fail to be able to safely implement the appropriate intensity. Now, we know that even at low to moderate intensity, we can stimulate muscle mass, but there is a quite reliable dose-response relationship between intensity of resistance exercise and muscle mass gains. Now, I will take a second to define this idea of resistance exercise. GP colleagues in the past have pulled me up by being a little unfamiliar with that notion of different types of exercise. And resistance exercise, when we refer to this, is the kind of exercise we're doing to elicit a stimulus primarily on muscle tissue, where the signs of resistance exercise are failure to perform repeated efforts because of muscle fatigue. So specifically, muscle fatigue is our key outcome. There are different types of resistance exercise that will elicit very different types of specific responses, and they relate to how quickly or how long an action needs to be performed. And all of these things are important to consider when we're prescribing exercise to elicit a response to fight back against the effects of sarcopenia. Now, something that we need to consider, and why I would labour the point around sarcopenia, is that there are a whole number of comorbid conditions that will both lead to worsening of sarcopenia or might lead to its considerable the incidence of sarcopenia of any great substance. And one of those will be skeletal integrity and osteoporosis, and there is a strong associative relationship between certain types of weight bearing and resistance exercise and very good outcomes in osteoporosis. And these actually turn out to be really good for developing muscle mass. So we can treat osteoporosis and sarcopenia concurrently. However, that type of approach will look a little more specific to the needs of osteoporosis. And it's really important to also highlight at this point that adverse events in studies that lead to effective outcomes for sarcopenia and osteoporosis have very, very, very low rates of adverse event. So it's exercise is a fundamentally safe activity when it's applied in a reasoned and evidence-based way. Oncological treatment is also a common way that we see sarcopenia expedited in older individuals' states. Now, that might be related to androgen deprivation therapy in the treatment of prostate cancer. It might be related to chemotherapy, obviously. We're quite aware of cachexia and sarcopenia that occur secondary to chemotherapy. Even in palliative chemotherapy states, we see those losses take place. And that's where it's really important for us to implement an exercise oncology approach to try and mitigate some of those losses so we can prolong quality of life as well as life expectancy. And we also see endocrine therapies that are often applied in the latter stages of breast cancer have an effect on muscle mass. And so it's important that we consider exercise as a treatment for those oncological presentations, as well as in the context of decline, or ever more so in the context of guarding against decline. Now, interestingly enough, metabolic disease, with specific reference to type 2 diabetes, is a really significant contributor to sarcopenia. In fact, there's this notion of sarcobesity, which is the concurrence of obesity and sarcopenia and type 2 diabetes because of altered metabolic function related to metabolic disease, and a whole number of processes that going otherwise unaddressed will lead to an expedited decline. The really important thing is there is a beautiful feed-forward mechanism from resistance exercise that lets us do wonderful things for individuals with type 2 diabetes. And so, again, we can treat concurrently these comorbidities. And that's why I think we really need to see more exercise physiology involvement in our care for residents in aged care facilities. The other obvious presentation that we're concerned about when it comes to decline is addressing neurodegenerative disease. And I want to suggest in helping to reduce polypharmacy. We also know that anabolic exercise, the kind of exercise that builds muscle mass, has significant effects on neurodegenerative disease. And then also, as I mentioned before, making sure that we have adequate nutritional intake gives us the building blocks for that anabolic exercise to do its job. And we have real and meaningful evidence that we can interrupt the trajectory of frailty and decline in neurodegenerative disease. A very good friend and colleague of mine, Michael Inskip, has been working for some time with the University of Sydney on this particular field. We'll be involved in a research project over the next 12 months looking at the effects of anabolic exercise in mitigating frailty and decline in individuals with neurodegenerative disease. So this area of evidence is still yet to be fully fleshed out, but all of the signs are there that we would have no reason to withhold this as a frontline treatment for individuals with these presentations. And then I also wanted to bring up the strong link between heart failure and cardiopulmonary presentations and sarcopenia. It's a really important thing for us to, while we're talking about resistance exercise as something that addresses muscle mass gains, resistance exercise can also be a key part in helping to facilitate healthier cardiopulmonary function. We know that individuals with respiratory disease can still increase the mitochondrial count in their working muscle cells, which will help to improve the efficiency of respiratory function. We know that individuals with chronic respiratory disease have less acute exacerbations of their chronic respiratory disease when they're actively partaking in maintenance exercise therapy and have graduated through pulmonary rehabilitation. And we have some limited but emerging evidence that there is some way that exercise can help to cut off serious decline in heart failure patients. But it would appear that we need to be intervening as early as possible rather than allowing decline be this something that we accept as inevitable. I want to lastly introduce you to what matters most, and that is the actual patients that we provide care for. That beautiful image there is not this person, Annie, that I talk about. That's my wife's grandmother that I've used for visual effect with my son's pet bearded dragon on her knee. That's why she looks so happy. It wasn't because we were talking about exercise. But I want to introduce you to a patient of mine. I'm going to call her Annie to protect her privacy. Now, Annie's been living in residential aged care for about 8 years, primarily because of issues around managing her mobility. Her spouse is considerably older than she is and unable to provide care for her in her own home. She also has bipolar 2 and is prone to episodes of self-harm. And she's a recent diagnosis of type 2 diabetes, but has lived with obesity for some time. And at the time of this episode of care we were providing, she had an HbA1c of 9 millimoles. We're having difficulty mobilizing any further than 50 meters with a four-wheel walker, and she needed to have one person with her to actively assist her. And we had problematic opiate dependence from a long-term opiate prescription, and her GP had recently taken over her case and was committed to trying to put in place an opiate taper if it was all possible to put into place. Now, I was fortunate enough to start seeing Annie at the beginning of the year. I was hot on to these item numbers becoming available, and I've in fact spent most of the last year trying to convince GPs and aged care facilities that these item numbers are a game changer for us. We haven't quite been so successful with getting widespread uptake of use of these item numbers. So I can firmly concur with Wendy that we need to use this or lose it. But what happened with Annie over the process, we spent 10 weeks working together. I do continue to see her now ongoing in a maintenance phase with a reduced frequency of attendance that she self-funds. But I saw Annie weekly for 10 weeks. Her GP had warmly regarded the use of all 10 EPC item numbers to our care. And one of the things that I find really important, particularly in delivering care into a geriatric setting, my background is in persistent pain and mental health, and no more so do we need to provide psychologically informed practice than into a residential aged care setting. Individuals experience a lot of anxiety when things are changing, when they meet new people, when they try a therapy that they perhaps previously haven't had value of or experience of. And even though we all know exercise is fairly tried and true, it's still considered fairly new by many patients who are not used to this kind of medical care. And so we, using psychologically informed practice, so we implemented some goal setting, we put into place some cognitive behavioural strategies, we put into place behavioural pain management strategies and pacing. We talked about some pain education, and then we integrated that with a slowly but surely graduated mobility-focused exercise prescription that primarily targeted trying to improve hip and knee extensor muscle mass. And then I worked collaboratively with her GP regarding her analgesia. So 10 weeks later, believe it or not, Annie was able to walk a couple hundred meters with her four-wheel walker. I was doing standby assistance, but she didn't need me, and she now, I'm glad to say, some 8 weeks after this point, is walking independently with her four-wheel walker, even taking a few steps with only just a walking stick or very light touch on surfaces. Her HbA1c is now at 6.5 millimoles, which for any of you who are keen on your diabetes management is pretty good considering the circumstances. She doesn't currently use any opiates, and I'm not going to dress this up and say that that was an easy process for her, but it was an active choice by all involved that she would prefer not to use opiates, and she's successfully managing well without them. We had some weight loss of 8 kilos over that period, and more importantly for Annie was really distressed by the fact that she felt inclined to self-harm. She would scratch her own arms and express her distress in physical ways. And we had no significant episodes of self-harm in this period of intervention. And so Annie is a special patient to me because of the nature of the gains we've been able to achieve together, and so having that strong therapeutic alliance is something that I think we all can attest to is helpful in achieving these outcomes. I don't want to suggest that all patients have such miraculous outcomes across all domains, but I can attest to the fact that the evidence isn't just academic around the efficacy of exercise in delivering powerful multi-morbidity change through using exercise therapy. And so if this is something that you've felt has been previously inaccessible to you in the care you provide to residents in residential care, then now is our opportunity to take hold and put in robust, innovative strategies that uphold the dignity of our older generation and help them to have the quality of life that we would so dearly like them to have. I'll stop there. If any of you have any questions, I'll be grateful to have those discussions later. Also happy to have any follow-up emails, and I'll let the presentation roll on.
Thank you very much, John. Thanks for taking us through the evidence. It's very good to hear that the kind of interventions we've been discussing have a solid evidence base. And certainly I can think of a couple of my residents already who I think would benefit from a more enhanced input from an exercise physiologist. So that's very helpful to hear. Thank you. I'm conscious of time, so I'm going to hand straight over to Ellen, who is a senior occupational therapist who has an interest in many areas that are relevant to what we're discussing. And please take it away, Ellen. Thank you.
Thank you, James, and thank you, John, as well. Good evening, everyone. My name's Ellen Marshall. I'm a senior occupational therapist with community therapy. I'm going to run through some of the care needs that occupational therapists commonly support in residential aged care. Many of these have become more prevalent with deconditioning related to the COVID-19 pandemic. So a brief little bit about me. I'm a senior OT working in disability and aged care. I've got some special interest in equipment prescription, manual handling and home modifications. Community therapy, we're a team of allied health. We're a mobile provider of 70 staff. We're a locally and family-owned business operating across the Central Coast, Hunter and Port Stephens regions. And we work across residential and community aged care and are an NDIS registered provider as well. Over the next few slides, I'm going to delve into some of the OT scope of practice that can be involved within the residential aged care setting. Previously, we have been a little bit limited by the funding models and what is provided by aged care facilities. So I'm hoping something like the current scheme will actually give OTs more scope to work within residential care facilities. And hopefully tonight I can give a bit more of an understanding of what actually OTs can do to support residents. So the first one is equipment prescription. So one of the more familiar areas of OT practice. However, the breadth of equipment that can be assessed for and prescribed within aged care settings is often misunderstood and not well known. The focus on equipment prescription is, to improve independence and safety as well. So whilst, we want to focus on reconditioning some stages where we actually have to focus on the next stage of their function and how we promote as much independence and safety at those levels as well. So we can range basic manual wheelchairs to semi-scripted power chairs, mobility equipment such as formal walkers, forearm support frames, complex bathing equipment, simple bathing equipment, so powered tilting commodes, things like that. Pressure reducing devices, and I'm going to go into a little bit more detail around pressure care in a few more slides. We also look at daily aids such as eating and drinking aids, adaptive cutlery, plates and drinkware, dressing aids, including aids to don and off pressure garments, and also dignity products. So we can also be involved in incontinence aids or dignity garments used for bathing and other tasks, and mobility scooters as well. So, we can complete the risk assessments around the safety of those to be used within an aged care setting, as well as some, residents will actually take them out into the community and we'd assess the risk around that as well. So manual handling is another area that OTs do work with quite a lot. We work within aged care facilities alongside staff and residents to assess the most appropriate methods of manual handling for each resident. And that includes assessing their care needs around ambulating and transferring and determining the most appropriate method and equipment required for transfers and ambulation. So this includes assessing the physical capacity, but also the cognitive capabilities. It takes into account behavioural concerns, and then we'd also look at the sizing of the equipment. We also conduct audits of equipment to make sure that the equipment being used is appropriate for each resident and that it's all in good working order as well. And one of the biggest parts of manual handling is the education that we can provide for carers and for residents as well. So that can range from comprehensive training, so broad spectrum manual handling training, which we can provide on site, or through platforms such as our online training modules. as well as individualised training for resident specific needs. And that probably comes into it more in relation to deconditioning, is actually looking at the very specific needs of the residents and understanding, what works best for them. It isn't a one-size-fits-all approach, and that's where the OTs can come and work with residents and their carers to determine the best fit. We also work, we can also provide recommendations around non-standard equipment. So some of the more out-of-the-box equipment that I've worked with in relation to manual handling within aged care facilities have been things like turning slings and actually air pump assisted turning devices as well. So these can be particularly important for clients that have deconditioned more. They may be more complex, non-compliant with, actually moving about themselves, and often as well for our bariatric residents. The focus for these is usually around immediate safety needs for the residents, whilst, as a multidisciplinary team, we basically plan, if rehab is possible for that client and if we can facilitate, improving their function that way. So the next area that I will delve into in a little bit more detail is pressure care. So pressure care is a common and essential area of therapeutic intervention for OTs, and an area where prevention really is key. One of those things that they're easy to get, hard to get rid of. So it's especially important in the current context of deconditioning and the COVID pandemic. Having an OT involved in pressure care assessment and management early on can be key in preventing wounds, and the physical, psychological and financial cost of treating them as well. So assessment will often include calculating a person's level of risk on their evidence-backed risk factors, as well as completing hands-on assessments to identify the presence of pressure wounds. OTs are also involved in assessing existing wounds to stage them and determine probable causes, and to identify then strategies for wound healing and prevention of further wounds. Education again is key in managing pressure care risk, as it usually involves high motivation and compliance from the residents and vigilance and attention to detail among care staff. This has been increasingly difficult in care settings where you can have high levels of cognitive impairment, such as seen in some of the more dementia-specific units, but also in relation to the challenges with COVID-19, where we've seen in some cases really rapid deconditioning of our residents, but also the high turnover of staff schedules. So Wendy did touch on it earlier, we've seen a lot of changeover in staff because staff are going into isolation because of, casual and close contacts. And as a result, we're just, not picking up on things, often things will get missed if you've got new staff in quite frequently. Knowing that person really well and knowing their risks and understanding their pressure care needs can be quite challenging. OTs will then look at treatment strategies, and that can come down again to equipment prescription. So the most commonly, easy examples would be cushions and mattresses. They're probably the most commonly understood ones that OTs assist with. But we might also look at more area-specific pressure reducing devices, such as heel elevators. And more often than not, it actually comes down to the overall positioning of the client. So you can see in my slide here, we've got one of our lovely OTs down filling up a ROHO cushion, which are a very high pressure care device and very easy. We go, yep, high pressure care needs, we'll pop a ROHO onto them. I've actually done pressure care assessments for people with coccyx pressure wounds who sit on a ROHO all day. Basically, the product hasn't been the right choice for them because that person actually needed more postural support and better positioning rather than just a high pressure care device. So the OT will actually come in and have a look at the person's specific needs, assess their pressure risk, and the most appropriate recommendations from there. The other area that's often also overlooked within the OT role, especially in an aged care setting, is around dementia and behaviour support and skill building in general. So with the increase in social isolation, limitations to social schedules, cognitive deconditioning is a serious issue, and one that can also directly impact physical decline also. So this might present in individuals as an increase in behaviours of concern or a general decline in their willingness or ability to participate in daily activities of daily living, such as just their self-care or feeding, things like that. It occurs in people both with dementia and without dementia. So whilst the slide is dementia and behaviour support, it really is a broad spectrum service that we can provide to any elderly person living in residential aged care. So where do OTs come into it? So we work with clients to build and maintain independent living skills. In some cases, this might just be focusing on improving their participation in a task. So we might not be working to engage, get them to be independent with showering. What we're wanting to do is actually for them to have more control in that task, a higher level of independence with that, and just to participate in that. We might also look at how we can amend or utilise their environment to improve their perception and interpretation of the world around them. So these strategies help to address and alleviate behaviours of concern and help educate staff in how best to support someone with cognitive decline. And for those, who do demonstrate behaviours of concern, we do try and educate and remind people that behaviours, they are a response to a particular situation, or a stimulus. So we want to, determine, what that is and how we can best improve that. So I've got a little bit of an example of how an OT might use meaningful occupations to build skill and manage behaviours of concern. So Dot is a 79-year-old lady living with dementia in a residential aged care setting. Since the COVID pandemic and resultant restrictions in social activities and visits from her daughter and grandson, Dot has become increasingly unsettled and disengaged from activities offered to her. She's also started hoarding washcloths in her room that she finds on trolleys, or she actually goes into other residents' rooms and finds them as well. So Dot was seen by an OT who, after talking to her for some time, discovered that she'd actually worked as a nurse for 30 years and that part of her role was to take clean washcloths to her patients' rooms every day for their bathing. So the OT actually worked with the staff at the facility and recommended that she was tasked with folding the washcloths each morning and then helping the staff deliver it to the residents' rooms in the wing of her facility. Since engaging in this activity, she started to re-engage with her normal routines, and she also attends the lounge probably each morning to tend to her task. So in many cases as well, we might refer to and work with other organisations like Dementia Support Australia, who offer additional services such as the Dementia Behaviour Management Advisory Service and the Severe Behaviour Response Team. So we would work closely with them and work on the best opportunities for the residents. So whilst this is a very brief snapshot of the OT scope within the aged care setting, I hope it did inform you, some of you tonight, of some of the areas and services that OTs provide within the residential aged care setting, or that we can provide within the residential aged care setting that you might not have been familiar with previously. The key take-home message for you guys tonight really is that early intervention is often key, especially in the context of deconditioning. So thank you again for having me here tonight to present and I hope, and to represent OT. I hope you have all learned more about the OT role in residential aged care and the value of OT engagement in managing and preventing both physical and cognitive deconditioning, especially in the context of the COVID pandemic.
Thank you very much, Ellen. Very interested to hear there about all the different ways in which an OT can assist, certainly some of which perhaps I wasn't aware of beforehand. So that's very useful to know. I particularly like the example about the lady with the washcloths, because again, I can think of a resident or two of mine where that intervention along those lines might also be helpful. So thank you very much for that. I'd like to open the discussion now to questions. Doesn't seem to be anything come through, but Wendy, I think you might have had a question for the allied health providers. I don't know if that's been answered, or if you have questions you'd still like to put to Ellen and John.
Thank you, James. Yeah, thank you to Ellen and John. Those presentations are really helpful for me to understand what services you guys are able to provide. My question to you is, and John probably answered a little bit with his actively engaging in the program, but is how do you think it will change your practice having the access to these initiatives? Perhaps Ellen.
Yeah, so as you kind of touched on, Wendy, historically OTs have been a little bit limited within the residential facilities with the funding model that's available. So, focusing primarily on pain management, the OT scope of practice is so much broader than that. And whilst I, as an OT in facilities, have still worked with a lot of the areas I talked about tonight, it can be dependent on what each facility is actually willing to provide and what they have capacity to provide and fund for their residents. So, hopefully something like this would allow more opportunity for at least, covering part of the way to have additional services in, especially ones that may have, not traditionally been engaged as often, such as OT.
Yeah, I was quite amazed at all the different things, particularly with the mental health components of the dementia. That's amazing, and that's probably going to be great for the other subsidised funding with the mental health ability to include OT in that as well. So that's really great. What about you, John? Do you think I know you've already changed your practice to encourage GPs to refer. How can we get them on board with this?
It's a great question, and EP is in exactly the same boat as Ellen outlined for OT. And when you mentioned allied health being, certain allied health services being mandated into residential aged care, I can't find exactly where that wording is, but I can tell you that the legislation predates exercise physiology as a formal profession. So I can tell you we won't be specifically mentioned, even if it can be somewhat weaseled in that we get a part of that action. But I'm optimistic with the new ANAC funding model coming up that should mean a better outcome for diverse allied health professions like OT and EP to do their best work. I really think that it's about putting the opportunities for care direction back in the hands of GPs. When I've spoken to GPs about their patients that are residents, they care about them deeply. They want there to be better outcomes for them, but they've often felt that they haven't had much say in what kind of care that they can receive. And I think that this is a really important step to put that back in their hands so they can make good choices about, the GP will be seeing all of these pressure sores coming up or can identify some of these concerns, and so they need to be able to call on the OT and not feel kind of hamstrung by by all the complications that are related to trying to deliver this care. So all in all, I think that this is a great first step, and hopefully by us all enthusiastically getting on with it in the next 9 months, we can see it get even better.
Yeah. James, what are your thoughts on that as a GP?
Yeah, look, I've learned a lot this evening, and I think there's definitely a shortfall, or in some way that the information dissemination has not been good on this. And as I say, I was not aware of certain aspects of this, and I think from your experience, Wendy, a lot of other GPs you've come across are the same. So there's clearly some work to be done about getting the message out there. But as I say, I've learned a lot, and there's definitely some stuff here that I'll take back to my facility and have some conversations with the management and so on there about enhancing the services that we provide. So it's been very helpful to hear about all of that. So I'd like to thank all three of you for your input this evening. Hopefully, I think there were some GPs in the audience this evening, so hopefully this will help to disseminate the message a bit further. So thank you very much, all of you, for your expertise, and to everyone in the audience for listening. And I will pass you back. I will pass us back to Charles. Thank you very much.
Great. Thank you, James. I'd also like to take the opportunity to say a big thank you to James, Wendy, Ellen and John. I appreciate the time that you've taken out of your busy schedules to not only present tonight, but to prepare all your content. So it's really, really appreciated. It's such an important issue. And as a fellow allied health professional, this is also close to home for me. So I'm always in big support of allied health, educating our primary care space. So thank you again. And of course, thank you to you for joining us and spending your time with us. I just wanted to cover a few things before we finish up. So just to remind you that the session is being recorded, and the slides also will become available from tomorrow in our PHN Education Library on our website. Session 2 in our series of 3 will be on chronic disease management within residential aged care facilities. And this is also being held via live stream at the same time in 3 weeks. So that's Wednesday, October 27th. So you can register for that session and the third session on the same flyer that I've sent out to you. If you don't have the flyer handy, just jump onto our website and click on our education events tab, and you'll see all of our upcoming events, and you can register via that way as well. You'll also notice that the evaluation survey for tonight has popped up in the polls tab on your screen. If you could take a moment to quickly fill that out before we log off, we'd really appreciate any feedback you can give us on tonight. We're always looking at how we can improve, how we deliver education, and also helps us to inform future topics that are of interest to you in primary care. So thank you again, everyone, for joining us. We'll leave it there. I hope you have an enjoyable evening. Good night.